is primarily used as a non-invasive, non-pharmacological method in patients with chronic stable angina and also with congestive heart failure. This may be especially useful in patients with severe diffuse coronary atherosclerosis and persistent angina in whom the coronary revascularization is not an option probably. So it acts as an option for no option patients, creating sort of a natural bypass. And to talk on this very interesting topic, we have Dr.S.Ramasamy, who is the Medical Director of International EECP Therapy Association, Tamil Nadu Government. I request our Dr. Bhupal to welcome him with a flower bouquet and then welcome to this program. In fact, he did his preliminary MBBS from our Davangere, and then now he is EECP consultant to various organizations, including Dr. K.M. Cherian Heart Foundation, and he has many awards, international and national awards, and also has many international and national papers, publications to his credit. I request Dr. S. Ramasamy to deliver the talk on EECP. Please, sir.
Thank you for the kind introduction, sir. Good morning. First, I would like to thank you all for giving me this opportunity to do a presentation in Jayadeva Cardiac Institute. I think it's known as, we know it's one of the renowned in India, and it is a privilege to have a presentation on EECP here. So today, my focus would be to say what is the role of EECP in clinical cardiology. As a doctor has initially given you an idea, EECP is a non-invasive option for patients with refractory angina, in the sense who are on maximal medical treatment. In spite of that, they are not getting a relief, and also they are not a candidate for interventional procedure. Either it is a bypass or angioplasty, or conventional treatment like bypass and angioplasty has been attempted, and patient is still symptomatic in spite of all the conventional mode of treatment has been given to the patient. So before actually going into EECP, I would like to refresh your memory on the basic cardiac hemodynamics. If you look at here, the lower one I have shown, systole and diastole, this is actually the coronary blood flow. If you look at during the systolic phase, there is an increased left ventricular pressure, and also, as you know, the coronaries are on the muscle, it gets squeezed by the myocardium. So the blood flow occurred during the systolic phase is very less, which shows around 20% of the blood flow into the myocardium occurred during the systolic phase. And if you see the diastolic phase, the maximum amount of blood flow actually happened during the diastolic phase. So what we call as the energy balance is supply diastolic pressure time and demand systolic pressure time. In the sense, it is a diastolic phase the coronary get filled up. The coronary filling is just a difference between the aortic pressure and the end diastolic pressure. So the coronary get filled up only during the diastolic phase. It has been known from 1950s. So you know cardiovascular disease or ischemic heart disease treatment is so complicated with medical management, intervention, and so many procedures has been adapted. If you want to make it very simple, the simplicity is there are only two conditions which we have to treat coronary artery disease or ischemic heart disease. One is a supply and second is a demand. If you want to increase a supply to the myocardium, you have mechanical manipulation. Either you stent it or you graft it, or you rotablader it, or endotracheotomy. All this procedure can able to increase the blood flow to the myocardium. And the second is a demand. So if you don't want to increase the supply, or the patient is a candidate who is not going for an interventional procedure, then you know how to reduce the demand. Demand is what the left ventricular oxygen consumption. So the left ventricular pump the blood into the peripheral vasculature. So if the peripheral vasculature are stiff, or increase peripheral vascular resistance, give a load to the left ventricular, we call as a myocardial load, and increase the oxygen consumption. So the simple way to tackle is medical management. We have your nitrate, you have your AC inhibitor, calcium channel blocker, ARB, all these things works through the demand. So it is actually a fantasy of every cardiologist and every physician from 1960s to find a treatment which can do both simultaneously. So it's not a surprise because we all know about intra-aortic balloon pump. I try to compare enhanced external counterpulsation is actually a non-invasive way of intra-aortic balloon pump. So we know intra-aortic balloon pump, it is a ventricular assist device and a circulatory support in patient with MI who have a cardiogenic shock. I mean the MI complicated with cardiogenic shock. So we all know about intra-aortic balloon pump, and very few know during the same time of what intra-aortic balloon pump has been introduced, actually external counterpulsation has been tried in various research in 1950s in MI and cardiogenic shock. It is in 1950s actually. Britwell, what he does is, they know that the coronary perfusion can be increased when you increase the diastolic pressure. So what he attempted is, he cannulated the femoral artery and he tried to push the blood inside during the diastole and withdraw the blood into the cannula during the diastole. It looks like a simple mechanical method, but we all know it actually doesn't improve any of the coronary perfusion. In fact, it causes hemolysis because of the RBC lysis. So then what happened, instead of cannulating it, they slowly advance the balloon close to the aorta, and they inflate and deflate the balloon in synchronized with the ECG. So exactly during the systole, when the heart is going to throw the blood flow and the pressure outside, the cuff deflate, and exactly during the diastole, the cuff inflate, so that significantly increases the coronary filling. So similarly, enhanced external counterpulsation, instead of the balloon is in the aorta, we consider the balloon is in the lower limb. If you see here, there are 3 sets of cuff, lower thigh and upper thigh. They sequentially inflate and deflate, similar to an intra-aortic balloon pump, but it's in the periphery rather than in the central. So this is how the treatment is given. This slide shows you a patient lying down on the treatment table with 3 sets of cuff, lower thigh and upper thigh region. The cuff sequentially inflate and deflate, pushing the blood retrograde back to the heart in the arterial end and increasing the venous return. This goes on for 35 days, continuously 6 days a week, so that the patient get clinical improvement. Now my presentation would here to focus to give you a clinical data to substantiate the claim that EECP significantly increase the myocardial blood flow, quality of life, and the patient can able to relieve the symptoms with the help of a 35 days of EECP treatment. So let's look at comparing the acute hemodynamics. What really happens during EECP? So this is what I've been explaining. Number first, ECG gated, similar to what we do in intra-aortic balloon pump. So exactly during the diastolic phase, the cuff inflates sequentially. The first one goes, and after 10 millisecond delay, the second one, and the third goes after another 10 millisecond delay. So what happened, the sequential inflation will push 2 compartment blood. One is a venous compartment and second is the arterial compartment. The increased venous compartment actually increase the preload and increase the cardiac output. And the increase in the arterial, which is a retrograde blood flow, exactly timed exactly on the diastolic phase. The aortic valve is closed, so the blood pushed into the aorta, get into the root and start filling the coronaries. So it increases the coronary perfusion pressure during the inflation of the cuff. And the second is a deflation, exactly when the heart is going for a systole. So during the pre-systolic phase, the cuff deflates, so that dilating the vessel, what we call as a significant reduction in peripheral vascular resistance. When the peripheral vascular resistance is reduced, the myocardium or the LV load is also reduced, because the LV can pump into the dilated vessel, so there is a significant reduction in oxygen consumption. So what I want to say is, it increases supply because of the retrograde blood flow and also decrease the demand. This happens during countercompensation for every beat continuously for 35 days. Now until 2002, it's a hypothesis that we put the compression in the lower leg, actually there is a change in the coronary blood flow or in the aortic blood flow. It's only an assumption. We have not confirmed by any clinical trial to show that it's really actually affecting the central hemodynamics. In 2002, one of our colleague, Michael, what he did is, he catheterized the patient, radial approach, and then he measured actually the coronary pressure during the counterpulsation to see what's really happened in the coronary vasculature. So you all know this is actually measurement of a pressure waveform. You have a systole, you have the dicrotic notch, the aortic valve closed, and downsloping diastole. So what happened is, they started giving pressure 100, 150, 200 and 250, slowly increasing the pressure in the lower leg by the cuff inflation. So that translates into incremental increase in the diastolic augmentation. You can look at the diastolic. There is a small blub at 150. By the time they went for 250, the diastolic augmentation is greater than even the systolic pressure. At the same time, I want you to appreciate the systolic amplitude is dropping. The dropping of systolic amplitude shows there is a significant afterload reduction. So the systolic pressure comes down and the diastolic pressure shoots up. So this is a demand is reduced, as well as a supply, which is directly related to the coronary perfusion pressure, significantly rises. So if you look at the diastolic pressure, it shoots from 71 to 136, which is almost a 92% increase in the diastolic pressure. And if you look at the Doppler velocity, the velocity increased from 18 to 45, which is almost 150% increase. Now you think there is a treatment which is increasing the pressure up to 92% in the coronary circulation and also the flow velocity. The pressure and velocity significantly increase. So the next question comes is, well, there is a significant change in the hemodynamic, it's fine. Would change in the hemodynamics have any effect on angiogenesis? Because of the ideology is EECP, if you increase the coronary perfusion and velocity, would have definite improvement in the collateralization or angiogenesis. The proof for angiogenesis can be given only for certain diagnostic procedure. Either you have to cath him to do the collateral flow index, or you have to do the perfusion scan to assess the perfusion imaging to improve the blood flow to the ischemic area. So this is what they did. From 92, there are a lot of small studies. In 2000 and 2003, we as a group took this as a challenge to give an objective evidence for cardiology community as well as the insurance reimbursement in US to show objectively there is a significant improvement of blood flow to the ischemic myocardium. And this improvement in the ischemic myocardium is achieved by a non-invasive method. So this is a classical paper we presented to the American Journal of Cardiology, which shows we took 175 patients. If you look at the demography, you see most of them have already attempted the conventional revascularization procedure. Either it is a stenting, angioplasty, or a bypass surgery, and most of them did have an MI. So they are already had an MI and already attempted the interventional procedures, and most of them are diabetic. So if you classify them, they are already a known coronary artery disease patient who are considered to be inoperable after the attempted interventional procedure. When we did perfusion scan before and after 35 days of EECP, this is what we found. When we do the perfusion scan, there are two ways to do it. Number one is same level of exercise pre and post. The guy which can walk on a treadmill for 5 minutes, even though he can able to walk more distance, we ask him to do the same 5 minutes and did the perfusion scan. 83% had a significant improvement in the perfusion scan to the ischemic area. And then, since he did EECP, definitely his quality of life improves and he can able to walk more distance. When you ask him to do walking more distance, what we found is still 54% have a significant improvement in the myocardial perfusion. This shows, in spite of the increased workload to the myocardium, the blood flow to the ischemic area has been restored. But obviously to 50 to 60% resolution of this ischemic defect clearly shows there is some mechanism happening which is creating what we call as an angiogenesis. And this is one example we did a study in our Frontier Lifeline in Chennai. We got an award winning in Hong Kong. What we did is we took patients who are severe LV dysfunction, who are anginal patient with severe triple vessel disease, inoperable, probably because they may have a renal failure, or the patient is not willing for a high-risk CABG procedure. So when you look at this, the perfusion scan, clearly before EECP, you can see there is a mild defect in the anterior wall, and there you can see the inferior and the septal or significant reduction in blood flow at the wrist and the apex. So post EECP, what happened when you did the myocardial perfusion? Visually, you can see there is a significant increase in the anterior wall as well as a septum, but still there is a diffusion defect in the inferior wall. But the patient EF shoots from 30 to 40, and this guy who was not able to walk for 10 minutes started walking for 45 minutes. So we achieve our target. The quality of life has improved, and with objective evidence to show there is a significant improvement in the perfusion. So if you look at that, the perfusion improvement is global, not localized to the lesion. So if you look at that, there is a scoring pattern of 1041 to 13,329, which is almost a 27 to 30% improvement in the perfusion. And finally, in 2009, two groups came forward, and one is from the Swiss and second from the Germany. This group directly cathed the patient, and by what we call as a gold standard angiogram, and they did a collateral flow index and found out in a randomized placebo-controlled trial, they showed patients with active EECP have a significant improvement in collateral flow index as well as fractional flow reserve. This clearly shows by invasive procedure, EECP does improve the collateralization, does improve the increased blood flow to the ischemic myocardium, which is activated through the increased blood flow which is achieved. This slide I want is a very interesting slide. It's out of the question of what I'm presenting, but what we call as a hemopoietic progenerator cell. And this is a very interesting because a lot of research is going on EECP in actually what we call as a regeneration therapy. If you look at the hemopoietic progenerator cell, this cell volume or the cell number is very high. It is a predictor of cardiovascular event. If it is very high, the patient incident of repeat myocardial infarction, hospitalization or MACE is reduced. But if the circulation is very less, and probably his event is going to be more. The reason is, these are all we call as a repairing cell. Once the level goes up, they goes and start repairing your endovascular problem and also the infarcted area or myocardial repair. So if it is less, your chances of getting a repeat attack is more. And incidentally, when they look at this, EECP significantly pushed this level very high, so that probably it might have some effect on the regeneration of myocardium, or it probably the angiogenesis. So you know angiogenesis, increased collateral flow reserve and increased myocardial perfusion. So let me summarize everything. So we have two sets of curve. In 2 minutes, I'll summarize what we have, the mechanism of action. The mechanism of action is two-pronged. One is it increases the flow to the myocardium by actively achieving what is called angiogenesis or arteriogenesis. At the same time, it does has an effect on the endothelial function because of the chronic increase in flow everywhere, not only in the coronary, but the entire systemic vasculature. What it does is, it improves the vasculature, increase the nitric oxide level, decrease the endothelin, which shows your endothelial function has improved or slowly moving towards the normalization. Both this effect together can able to improve the patient condition. So now let's go to the clinical outcome. So we spoke about a lot about the mechanism of action. If so much can occur during the EECP, what is the clinical benefit the patient might get after the 35 days of EECP? So if you see here, there is a significant increase in nitric oxide, decrease in endothelin, decrease in BNP, and hemodynamically, the patient who undergone 35 sessions of EECP has shown to increase cardiac output as well as ejection fraction and stroke volume, and there is a significant reduction in the blood pressure and heart rate. So clinically, the patient may be able to walk more distance than before, and some of the on-demand nitrates intake like sublingual nitrate or nitrate can be reduced, and also there is a significant improvement in quality of life, and the benefit the patient get after 35 days of EECP has been shown to last up to 3 to 5 years. So this is a registry which have in EECP which more than 7,000 patients. If you look at the demography, you know what is a patient selection. You look at here, most of them have multivessel disease, 80%. Some of them are heart failure, and some of them, 87% has a previous intervention procedure already done. So this is a group we call as inoperable, and because they have already attempted interventional procedure, or they have a diffuse vessel disease, or they have a comorbid illness, preventing them go for a conventional treatment. So they did follow this patient with preserved LV function who have angina, and they did 35 sessions of EECP, and this study followed them up to 3 years and found out almost 75 to 80% of the patients were able to retain the benefit even after 3 years. And also please remember, they are not a simple anginal patient, they are the patient who had MI with associated complication. They would have gone for a cardiogenic shock, they gone for a LV dysfunction, they have a comorbid illness. So these are a patient with complex coronary anatomy where they cannot go for an interventional procedure. In spite of that, they have a good clinical outcome, and they were able to have a quality of life maintained for 3 years. And just to show that there are a lot of studies going on that elderly population, diabetes, patient with severe LV dysfunction, with comorbid, all have shown robustly around 70 to 80% were able to retain it up to 3 years. So the second challenge comes in heart failure. So we all know heart failure is a dreaded disease. Reason is that we don't have a cure for it, and we have in our clinic, we see a lot of patients who are on maximal diuretic therapy. They don't respond to the diuretic therapy enough, or you put them on a diuretic therapy, they come up with a fainting spell and hypotension, and so we cannot improve the diuretics, but they have pedal edema, or they have been cannot go for any other procedures. So these group of patients, when they do with EECP, what is the clinical outcome? So we found out After EECP, there is a significant reduction in emergency room visit and hospitalization. So this amounts about 86% to 83%. It is very significant in patients with heart failure because they utilize a lot of resources in any hospital or any private or any cardiology institute. They come with repeat hospitalization, repeat complication, fainting spell, pulmonary edema, and all these things. In spite of that, the 35 hours of EECP have shown to reduce the repeat hospitalization. It's not a randomized trial, so I can make a conclusion, but it does show that it has a trend towards reduction in hospitalization and emergency visit. So we did a study to follow them up to 2 years. So you look at here in 2 years follow-up, almost 9% of them, they underwent for emergency CABG or PTCA. So it probably a ACS or acute coronary syndrome. And 30% has MACE in 2 years. So when compared to the previous trial on AC inhibitor and calcium channel blocker on a patient with severe LV dysfunction, this 30% in 2 years is significantly less when compared to just putting on them on a medical management. And when we follow up them, 55 to 60% were able to retain the heart failure symptom, in the sense they don't go for a repeated heart failure symptoms in 2 years, and they have quite a good survival. Almost 83% were able to survive. And if you look at the demography, these are all the patients with EF less than 35 or 30%. We call it as a severe LV dysfunction. So patient with severe LV dysfunction, we are able to maintain their quality of life and able to keep them out of an emergency room or repeat hospitalization with 35 sessions of EECP. So let's go for a patient selection. Number one is patient who use EECP as a primary option. These are the group. They are on maximal medication, and intervention is not an option for them because of various reasons. Number second is diffuse vessel disease. The target vessels are not available, or they have a distal vessel with a diffuse, or the vessels are very thin, or grafts are not available, or they have already gone for an intervention and they come for a restenosis of graft occlusion. In some institution, even Chennai, we prepare the patient with high-risk CABG with EECP and trying to avoid IABP insertion during the CABG procedure. And obviously, patient with heart failure, both ischemic and non-ischemic, and cardiac X syndrome. And right now, cardiac X syndrome, there is no other treatment. You have a microvascular disease, you cannot be stented or grafted, and EECP would significantly improve the myocardial perfusion because the vessel which is diseased are microvessel which cannot be attempted by conventional method. So this is a FDA indication. So have an indication of class 2 to class 4 angina or class 2 to class 3 heart failure. And what would be the contraindication? Similar to what you see in intra-aortic balloon pump. We don't want to treat any patient with severe aortic regurgitation because when you're pushing the blood, you may push into the left ventricular and you may worsen the heart failure. Or patient with deep vein thrombosis, or patient who have aortic aneurysms, or patient who have decompensated heart failure. These are all absolute contraindication for EECP. So I just want to give you a current status. In 2012, there are a lot of information on EECP because number one, the American College of Cardiology classify EECP into class evidence B and class 2B. It shows one randomized trial and large non-randomized trials are available, and this treatment may be considered in patient with refractory angina and heart failure. But in 2013, the European Society of Cardiology guideline went ahead one step ahead, and then they said is a level of evidence B and 2A. 2A means it's a conclusive evidence that the proof of improvement has been well established, and so any patient with refractory angina should be considered for EECP. So, must be considered for EECP. From maybe to must be is a big improvement in the way of classification for guideline. And from 2011, you can see various test books has been written on EECP and chapters has been allotted for EECP. And 2010, Indian Heart Journal, we wrote a review article for patient selection and for patient how EECP can be applied. And to summarize this, EECP is FDA approved. It is in the recommended guideline of American College Cardiology and Heart Association as well as the European Society of Cardiology. And 2 or 3 slides, I want to give this novel program they started in Tamil Nadu government. In Tamil Nadu government, They started EECP in all the medical college hospital, and it is reimbursed by the Tamil Nadu health scheme. And what they said is this has been considered and this has been employed and what we call as a non-invasive ischemic burden reduction program. So this EECP has nothing to do with interventional procedure, which we used to do with a conventional method of block. So it is a mechanical manipulation or the anatomical load. So here we are not looking at the anatomical load, we are purely looking at the ischemic load. So how we can able to do a treatment other than medical management and reduce the ischemic load so this patient can be put back to increase quality of life to prevent them to come back to the hospital frequently. So these are all the hospitals like Vellore, Kilpak, and these are all the medical college we already initiated EECP. And the objective I said is to help this patient with poor heart function, advanced age, who are not willing or not a candidate for intervention, and to get this EECP to across as many as district hospital under the cardiology guideline to have a medical management along with EECP into this inoperable group of patients. So this is a very interesting, out of 575 patients we did in EECP in Government General Hospital in this scheme, you look at 41 are absolutely inoperable group, and 59% probably they are an operable group but high risk. And so the interventionalists and the surgeons opted for EECP and put them under the follow-up and taken for a bypass or angioplasty if it requires at the later stage. So this is a program. The patients are referred to the cardiology department. From the cardiology department, it is referred to the department of EECP run by the private partner. And if the insurance approves it, they treat and get the insurance reimbursed. And the separate website has been created. So the patient outcome, treatment procedures and everyday procedures are remotely monitored through the website. So this is a typical EECP center in the government which has 5 missions, and they were able to treat around 50 to 6 per day. So this may not be an academic slide, but I thought I would put it because with the help of our president, we have EECP installed in Rashtrapati Bhavan for the First Lady, and he was so generous to ask us to put this slide with them and also show the recommendation letter which has given to us, appreciating that the First Lady, typically a refractory angina, inoperable group, who significantly improved after the 35 days of EECP. So he did have a EECP program set up in the Rashtrapati Bhavan's private physician chamber. So as to put the conclusive, you have a treatment which is very safe, which you have shown to improve the collateralization, improve the endothelial function, and also normalize the neurohormonal level, as I said about the renin and angiotensin level, and also some of the nitric oxide and endothelin. And it has been shown significant improvement in patients with refractory angina and heart failure. So overall, there are more than 160 publications are done on EECP in national and international, and also there are 7 randomized trials. So conclusively, this shows you have an option of non-invasive treatment which can be used along with interventional procedure in a selected group of population where there is a significant benefit not only in quality of life, they may be able to improve their ejection fraction. Some of the objective means, as I said, by angiogram and perfusion scan can show a significant improvement, and the patient quality of life can be restored. With that, I will conclude my speech. Thank you. Yes, ma'am.
2 decades ago, this was introduced, and at that time, it did not succeed. And now that you say that it is useful, what changes have you made that then it was not useful and now it is useful?
One.
The second question
is, these pads are for the adult. Have you got it for the children, where the dilated cardiomyopathy or post-viral myocarditis, they are sick, or Kawasaki, like that? And the third one is, what's the cost?
Okay. The first question is, EECP was introduced in India probably some 10 years before. As doctor has mentioned, 20 years before, when they introduced EECP, they were not giving this. Actually, that is why I put one slide we call as a sequential inflation. When they inflated the cuff, in many of the Chinese systems, they still use that. All the cuffs were inflated same time and deflated at the same time. If you think logically, what will happen is, when you inflate the cuff simultaneously, there is a bottleneck effect. So many studies which they did previous comparing with IAPP, the coronary perfusion flow or a diastolic augmentation is very, very less. So we might not have any amount of collateralization in the central circulation. So that is a failure. And second is, purposely I used 2 slides. Why there is a significant increase of interest? Number one is because of the study pointed out by Arteriogenesis Network. This is a big group in Germany. They purely work on arteriogenesis and angiogenesis. When they did a trial with EECP, placebo control, they have another group, they come for EECP but no pressure is given. They come for 35 days, the other guys take an active counterpulsation. When they did the post-occlusion, we call it as a collateral flow index, there was a significant improvement in collateral flow index. This amount of blood flow or the collateralization have not occurred even in major studies like colony stimulating factor. That was considered to be the future in angiogenesis. They introduce the colony function into the myocardium and they look for the increase in collateral. What they achieved with that, it's absolutely not equal. EECP was able to achieve much more than that. So these 2 reasons given a sudden increase in burst on EECP activity across the world. And obviously the second growth is going to, some of the insurance company in US and Europe are coming forward and said, we are going to reimburse EECP for heart failure. Right now we are talking about angina with compromised LV function or preserved LV function. But directly for heart failure it is not Medicare approved, but FDA has already approved. But one Medicare approved, there will be a huge amount of patients for heart failure. Because these are the group we are looking at, nothing can be done. They just come to the hospital repeatedly. And second is, actually there was study, but the pediatric cuff or this has not been approved by US FDA so far. But there are certain countries like no regulation like China and some of the European countries, they are doing trial on patient, kids to increase the flow into the blood flow. But it is not approved by FDA, saying there is insufficient data available to substantiate the claim that EECP can also be used in the infants. They think their circulatory pattern is different than what you see in the adult. And the third one is, this system is costing around 60 to 80 lakhs. Is the Vaso Medical. This is the EECP, this is the imported, and all the trial which I have shown you, they all came from one single company called Vaso Medical, and they have the proprietary technology which have the inflation and deflation. So this is a cost of the equipment. But in the market, I don't know, we all know there are a lot of systems now copying which call as a Chinese model. We cannot comment, but we don't know any clinical evidence to substantiate the use of the machine in the patient. It may be used, it may be as equal to EECP or it may not be, but there is no evidence to point any.
The cost to the patient, once patient comes for 35 days, what will be the cost of?
Yes, sir. I mean, I would say in India, because there are more than 100 systems. Yes, throughout India there are more than 100 centers. So if you ask for exact price, it varies between 80,000 to 1.1 lakh. Some hospitals do pre and post perfusion as a package. So that is outside. But what Tamil Nadu government did is, they asked us to put up a public-private partnership model. So the government gives us a free space in all medical college. So what they said is, because the government space is provided free, and these treatments are given under the scheme to all the below poverty patients free of cost. And the insurance reimburses around 55,000 rupees.
That's for one sitting,
35 days. This is for the whole course, 35 days, not for one sitting.
Then after the next sitting will be when?
See, throughout, I think the registry data, in 5 years follow-up, 22% came for repeat procedure. So the insurance in US, we don't have a policy in India, but the insurance in US automatically reimburse EECP if it is after 2 years. And Tamil Nadu government, I think there are certain patients who came back within 8 months. And after 1 year, they are ready to reimburse the EECP. So every year, below poverty line, if they come up, they are ready to reimburse for EECP. But
only 35 days, why not 30 days or 25 days?
Yeah.
What is the basis?
That's a very good question. Actually, initially when they started EECP, and they given the EECP for I think 8 to 12 sessions. When they did 8 to 12 sessions for refractory angina, and there is no significant improvement, only 20% of the patients shown there is some improvement. So what they did is they tried to increase it and followed by the perfusion scan. So actually around 30 to 35, the output came around 85 to 90% of the patients, they said significant improvement clinically. It's not about objective. So what they did is around 30 to 35 session has been considered as an optimal treatment session to have a maximum amount of patient have a clinical improvement. So universally it is fixed around 35 days for EECP. That is approved protocol for FDA, and all the countries they follow the 35 hours treatment pattern, 1 hour a day, or in some patients with normal LV function they can do twice a day, can close within 18 days.
All these patients are on end-stage chronic stable angina, diffuse disease. They are going to develop collaterals over a period of time. How do you claim that your EECP only is responsible for neovascular? How can you do it? Because all of them have a chronic stable angina. There will be collaterals developing by themselves without EECP.
So what I would say is,
how do you say it is due to EECP?
This is a typical question asked in all the conference. Number one, the collateralization happens in human being. Obviously, no. I mean, if you have a obstruction, there is a collateralization. But obviously, the phase at which the collateral form cannot outwit the MI. So possibly, when we talk about class 3 and class 4, they may have collateral, but they have insufficient collateral to decrease the ischemic burden. They still have an ischemic burden. That is why they come with class 3 and class 4. So obviously, collateralization can occur, but it has not phased out that the symptom is still there. So it obviously means the collateral is not sufficient for him to take over of his regular activities. So obviously the collateralization has to be improved. And there was a very good study shown. What they do is collateralization can happen in athletes.
You did the randomized studies.
Yes, the randomized study. Athletes just develop collaterals, but cardiac patients cannot be athletes because they cannot even walk to their bathroom. So we cannot ask them to do regular exercise. So what EECP does is, it does shear stress in 3 ways. It increases the flow during diastolic phase. Even athletes cannot achieve that because diastolic phase is lower. Here diastolic augmentation. Number 2, EECP increases the preload and increases stroke volume and cardiac output. So the shear stress to the vascular endothelium is 3 to 4 times than you are doing an aggressive exercise. So that amount of shear stress has been translated into increased collateralization. And trust me, we did a lot of study. Collateralization, actually it is a very slow pace in human, and humans are actually cursed because dogs and pigs can develop faster collateral than human. That is why our TMR all fail.
That's the TMR. Another question. What are the local components?
During the procedure.
During the procedure, you were
Yes.
sick. Do you have any muscle fibrosis, muscle ischemia, anything like that?
No, actually the procedure, number 1, first 3 days they may become a little bit tired, and muscle pain, usually 3 to 4% only discontinue because of muscle pain. Otherwise 98% they complete the treatment. And if you go clinically in patient with stable angina with preserved LV function, you would not have any complication. It's just like a simple treatment. But the challenge comes when you treat patient with severe LV dysfunction with EF less than 30%, because there is a 5% chance that the preload you are pushing in may convert it into pulmonary edema and patient may end up in the pulmonary edema. So our deflation and inflation has to be very careful, and medical management has to be very careful when you treatment patient with a LV dysfunction. But normal LV function, we don't have much of a
Is there any implication in the renal function, because you are squeezing the muscle? It's going to cause a lot of micro damage. Creatinine level is going to be high.
No, sir. Actually, it is what we thought is in a patient with low output syndrome, when the cardiac output is low, the blood flow to the renal, creatinine level goes up. Actually, we have shown study EECP decrease the creatinine level and urea level if it is because of the vasculature and because of the low output.
No, I'm not talking about the simplest thing, because it's squeezing the muscle. When you're squeezing the muscle will have some amount of ischemia. So that ischemia will cause some raise in
Muscle
creatinine.
Muscle creatinine.
Yeah, muscle creatinine. Is it going to affect the renal, because they already are in low status?
No, sir. I think none of the study we have done have shown any deterioration of renal status or because of EECP any muscle injury or renal failure. So we think it's absolutely safe in having a pressure of 200 to 300 millimeter mercury pressure, even in patient with LV function or with renal failure. It's absolutely safe.
In other words, my question is, can you use it in patients who have got compromised renal function?
I think there is a study. There is a study going on in Germany in patient with dialysis. They are using EECP along with dialysis to see whether the number of dialysis can be reduced. So I may not say it is beneficial, but I can be very confident to say it is safe to give in patient with renal failure. Yeah, I think. Yeah, I can tell them. Yeah. So the procedure is simple. They have a cuff. The cuff has 3 parts: the lower calf, lower thigh, and upper thigh region. So they tie the cuff, and then obviously it is ECG gated, same as IABP. So if we put a ECG, 3-lead ECG, and it is synchronized to the computer. So the inflation and deflation time are ECG gated with microsecond precision. So it looks at his heart rate, and we have a saturation probe can be seen, and this is the ECG. He has to stabilize the ECG now. So now you look at this. This is his heart rate, around 80 to 90, and you can see the ECG. You can increase the amplitude. So the marker you are seeing is actually we can control when we can inflate and when we can deflate the cuff. So the inflation and deflation can be manual or it can be in the auto mode. So same as IABP, the inflation happens exactly during the diastolic phase, and the deflation of the cuff occurred during the systolic phase. So you can see the QRS complex. The first one is the inflation and it ends in the deflation. The blue mark shows how much time the cuff is kept inflated. Yes, sir. I think couple of centers. How many centers? 2 centers. 4 centers are there. See the finger plethysmogram waveform you can see here. So this finger plethysmogram can be monitored to see the diastolic augmentation. So in IABP you put a catheterization into the aorta, but since it is a non-invasive, you won't catheterize the patient, but we put a small probe in the finger so that the wave analysis can be done. Another deep breath. Now you have the inflation and deflation. As the heart rate changes, the system automatically changes the inflation and deflation according to the heart rate. So this is in an auto mode. So what we do is we have a pressure 80. So when you're on the machine, the pressure starts with 80 and the maximum we can go is around 300 millimeter mercury pressure. If you just recollect my slide which I shown, the central hemodynamics, around 200 millimeter mercury pressure when you reach in the cuff, there is a significant increase in the coronary perfusion pressure. So that is kept constant for 35 days. So what the treatment does is something like a increased blood flow across your vasculature, not only in the coronary, entire systemic vasculature is thrown into a shear stress, which improves the endothelium as well as the collateralization. Now I can on the machine. You can see that is a dicrotic notch. So many times people ask whether it is a comfortable treatment, but we have did patient even with 90 years old, and the first 3 days is what they complain, because they keep the muscle stiff when you apply the pressure, and after 3 days we see almost 30 to 40% of the patient they sleep during the treatment. So it's not a very uncomfortable treatment, and probably 3-4 days there will be a tiredness and some muscle aches, as he was pointing out, but later I think it should be a very comfortable treatment for anybody. So same as IABP, if your heart rate goes beyond 100, then rather than making in 1:1 mode, we can shift into 1:2 mode. 1:2 mode means alternative beat only it will capture. So even with a tachycardia, we may able to do EECP without any problem. You can see the second wave forming is actually the diastolic augmented wave. If you see here, rather than downsloping, you can see there is a small blip. So the diastolic pressure slowly increases as the treatment progresses. By 15 to 20 minutes, the diastolic augmentation will go beyond the systolic. So exactly what we do is a increased coronary filling pressure, which is the diastolic augmentation. So that is achieved throughout the treatment, and the patient heart rate is monitored, oxygen saturation is monitored. What is it? Sir.
How comfortable were you?
Uncomfortable, sir.
You look quite anxious.
So he's from the center, he wouldn't say anything, he'll be saying only comfortable.
What happens in a normal community?
Yes, sir?
What happens in a normal
Government
who doesn't have
doesn't have. So since it's like a physiological procedure, I don't think much. Yeah.
What in case while doing the procedure? Fatal earthquake takes place.
Which one, sir?
Fatal earthquake takes place during the procedure.
We have to stop. Actually, in patient with that severe LV dysfunction, because we do have, yeah.
Heart patients, placing that diastolic function improve, and the body and their patients who are going to improve fine. That is the positive aspect. Negative aspect is during the procedure, because irritable myocardium, arrhythmias are well known.
Yes.
Most of them they die with fatal arrhythmias, so we can be a very. So doing that procedure, people will not be ready to monitor.
No, that's what I said. See, when you go for this heart failure, because in our center, KM Cherian, we have a heart failure clinic where we put EECP. We take end-stage heart failure, patient who are posted for heart transplant and they're waiting for the heart transplant. Definitely, we do have this. Sometimes patient may go for pulmonary edema and they have a VTAC or arrhythmias. And all the center which you do heart failure clinics, even in the government setups, are close to ICU. So when you do an anginal patient with preserved LV function, the complication of having an MI is 0.01%. The same time, when you do a patient with severe LV dysfunction with a recent history of hospitalization or pulmonary hypertension, their chances of going for a pulmonary edema is 5 to 10%. So we do have risk if it is not properly done, properly monitored. So like say, 2 times the patient preload keeps on increasing and they don't auscultate, saturation drops, patient has a mild pulmonary edema. If you continued 4th day, they have a flash pulmonary edema. There are incidents reported, and we do see in our routine. Out of 600 patients, we have a monitoring team for Tamil Nadu. So far, only 2 patients had pulmonary edema who require hospitalization. I think one paper was presented by Fortis group that they had shown some improvement in the MR, which is because of ischemia. Because many times we are also doing a study, ventricular remodeling. So when you have a dilated LV, After 35 days of EECP, we will do the echo by Simpson method and assess the LV volume and LV diameter. And we have shown one paper which is presented in ACC that did reduction in the end diastolic volume and end diastolic diameter. Yes, sir? Follow-up study is not done, and after that we do only clinical assessment. So I don't think I have a follow-up echo to show whether that is maintained.
Did any of your studies have a sham?
I think 7, that is a 7 randomized study, all sham control. If you look at that angiogram, pre and post, that is sham control. And the perfusion scan is sham control. And there are almost 7 randomized trials. Sham, what we do is the treatment is a patient come every day for EECP and they would have been not informed, or the investigator who is looking at the result also don't know which one is going for a sham and active. And what we do is we give a pressure of 80 millimeter mercury pressure. So it gives a sound, it gives a pressure, but we know that pressure is inadequate to raise any of your central parameters.
All options are exhausted.
Yes, sir.
ECG gate.
If you have uncontrolled arrhythmias, AFib with irregular QRS complex, sometimes it's very difficult. Unless we control the rhythm, we may not, because as you know, it is ECG gated. There are a lot of disturbance would be there, and probably they might not get the optimal benefit. Because before the cuff inflate, the second PVC or something comes, the cuff will deflate. So they might not have the adequate pressure to achieve the clinical benefit. So if the ECG, I mean, if you see arrhythmias and all these things, atrial fibrillation with irregular QRS complex, it's difficult to treat. And usually we give them 5-10 sessions and ask them to increase the medication and come back again to see whether the arrhythmia subsides. Otherwise we cannot take.
Thank you, sir. There are no more questions. We conclude this session, and I thank Dr. Ramasamy immensely for enlightening on this novel topic, the EECP, and also special thanks for our person who was there for demo, Mr. Rohit. Yeah, thank you, sir. Okay, I request Dr. Prabhavati to give a flower bouquet to Dr. Ramasamy. Please come out to the stage, madam. And I thank the entire team members for having made this program quite informative program. And after having food for the brain, and it's time now for have the food for the tummy. And we have the lunch arranged. Kindly come out to the lunch and then we can discuss later. Thank you one and all.